Thank you. It's really, really lovely to be here, and it is nice to have more notice this time. So I thought what I'd do is, first of all, give you a little bit of an introduction in terms of the work that I've been involved in over the last couple of decades. And I was asked specifically to talk about the evidence around risk factors. So how we can understand those both in terms of a general sense, i.e. the risk factors that we know lead to mental health problems, but also specifically in the context of eating disorders. And also I want to talk a little bit about the work that we're doing to try and empower schools and teachers and give them confidence in being able to tackle these issues. I think we have a really amazing opportunity, and I'm really, really keen that academic scientists and people working clinically work in collaboration with schools. I think it's very, very important. Okay, so I'm a behavioural psychologist. I'm interested in why people do what they do and think the way that they think. And for the last 20 years, I've been involved in research and leading research into eating disorders. I've done lots of work on compulsive exercise. So we developed the first treatment to try and help people to manage their over-exercising, which is a common symptom of eating pathology, and develop measures, clinical measures to screen for those conditions. But I've also done lots of work with parents and with schools, looking at the sorts of interactions that people have with children, both teachers and parents, around their eating behaviour, around their physical activity behaviour, and looked at the way in which some of the mental health concerns that we are seeing in this group are perhaps not helped by some of the interactions that children are having. In addition to that, we've done lots of work in laboratories looking at why people make the choices they make about food and eating and how that relates to obesity. So looking at obesogenic eating behaviours and things like emotional overeating, as well as broader mental health and well-being measures. So we've heard, I'm not going to insult you by telling you that there are lots of mental health issues in schools. What I will say is that there is evidence to support the fact that there's lots of mental health issues in schools. In terms of eating disorders, the latest study suggests that 30% of girls and 14% of boys are at risk. Now, obviously, you can read 10 different studies and they'll all come out with different prevalence rates. Depends which measure they use, depends on the context of the research, but that's pretty typical if you look across the studies. Obviously, we also see anxiety disorders. We've spoken a lot about stress. Around 19% of senior school children have an anxiety disorder, and depression, about 4 to 5% have a major depressive disorder. Self-harm is hugely problematic. These figures, 14% of boys and 25% of girls, that's within the last 12 months. The latest study suggests that that's the sort of figure that are being reported. And then the other area that I've done quite a bit of work is around gender dysphoria. So up to 1.5% of people have a transgender kind of clinically significant disorder that requires intervention. And then obviously we have drug and alcohol misuse. Now, I'm not even going to put figures there because they are a vast underestimation of any problems that are out there. And I think we've made the point already this morning that this is scratching the surface. People do not disclose these disorders. So whilst these figures look high, they are certainly not as high as the true prevalence rates. So in terms of kind of looking at gender differences in these conditions and really just alerting people to what they might be looking for, we see much more internalising disorders among girls than boys. So disorders like depression, social anxiety, eating disorders, 12 to 23% prevalence in school-age children. And in boys, we're more likely to see the kind of disruptive disorders, so around conduct disorders, that sort of thing, 5 to 10% prevalence. And that's just the children. And I say that partly in jest, but actually I really mean it. I mean, not just because I've got, within my family and my top 5 friends, I've probably got, half a dozen teachers who I talk to regularly. But also, I think it's really, really important that we look at teacher well-being. So teachers are role models. We're asking teachers to pick up on mental health concerns when lots of teachers have their own mental health concerns. You know, all of the teachers I know have periods of stress. Some of them have chronic stress. Some of them have left the profession because of stress. So teachers get mental health issues too, and I think it's really important that together we direct some resource to that. Anyway, back to children. Actually, this isn't just about children. These are risk factors that affect anyone, whether you're young or old. So I'm going to talk about some of the general risk factors, so the things that we know from the evidence base lead to higher incidence of mental health problems. Lots of them are to do with familial factors. So, for example, we've done lots of work looking at over-controlling parenting. Now, this isn't going to come as any surprise to people in the audience, but those parents who perhaps don't allow their child to develop the self-regulation that we've heard about as being so important. Not allowing children to find their way to solve problems. You know, the parents who are always there, always involved, you know, they're in school at the drop of a hat. We know that leads to higher levels of mental health problems. We've then got lack of care and supervision and lack of interest. Now, clearly we have an issue around perhaps children who don't get the support that they need, and that can be for a variety of reasons, not least in some of the schools that we're working with around opulent neglect. You know, this isn't about not providing food and resource for your children, it's about not providing time and support. We've done lots of work looking at a construct called invalidating environments, and I'm going to talk about that in a little while. But it's about allowing the child to feel valued, and there's ways in which parents can do that. We also know that parental conflicts, separation, divorce, it's just one of those other things as a parent we have to feel guilty about, but children who come from families that have these sorts of issues are more likely to have mental health problems, and as well as mental health and criminality in parents. General factors. Okay, more outside of the family, so peer group related risk factors. We know that children who have ties to peer groups that are more delinquent, less socially adjusted, are more likely to develop problems themselves. Bullying is a huge thing. Least of all, cyberbullying has already been mentioned, but bullying in schools we know leads to high levels of self-harm, high levels of eating disorders, high levels of depression and anxiety. And then we've got the socioeconomic and cultural risk factors, so things like poverty, living in deprived situations, and also being from an immigrant background, which of course is becoming more and more important for us to understand why and what we can do about that. So they're all general risk factors. If people are in these sorts of situations and grow up in this sort of environment, they are more likely to have levels of pathology that are problematic. I'm going to use eating disorders as an example to give you some specific risk factors now. So I'm going to talk a little bit about the risk factors and what causes eating disorders. We know that there's no single cause. This isn't about, media pressures to be thin. This isn't about parenting. It's very, very complex. But what we do know is that there are multiple risk factors that converge upon two key elements, and we've talked about them both already this morning. One is low self-esteem. Now, I know as a psychologist, I've been accused of using phrases like low self-esteem, and it's one of those phrases, isn't it, where you think, oh, God, they're at it again. I cannot stress how important this is. People who have eating disorders do not feel like they're a worthwhile, loved, valuable person. They feel like they can't do anything right, that they're hopeless. And even if they come across as being very outgoing, very socially able, underneath, they feel terrible. It's fundamental across these disorders. The other thing that they have is high levels of perfectionism. Now, again, we've talked about that striving. We've talked about, don't even get me started on A stars. Why is an A not good enough anymore? Yeah. So these levels of perfectionism are very, very high, and you can kind of see why those two things go together. I feel terrible about myself. If I can do really, really well, if I can be the best at my studies, the best musician, the best hockey player, then I'll feel better, and I'll be, people will value me more. And when people have these two kind of almost juxtaposed cognitions, that contributes in some individuals for this need for control. They need to do stuff that's really in their control. So we see things like OCD, where people are having to control their environment, and we also see eating disorders. Now, for these people, obviously that need for control gets focused on eating shape and weight. And we think that's probably due to psychosocial factors. Why does one person develop an eating disorder and one person develop OCD? We suspect it's due to those ridiculous social and cultural expectations that are placed on people to look a certain way. And I don't just mean women looking thin, I now mean men looking muscular, etc. So we're looking at things like media images, teasing, socially comparing oneself with others, and the internet and social media has a big, big role to play in this. But that's why it gets focused on eating shape and weight. That's the current thinking within the field. Now, in terms of risk factors, so we know that eating disorders are more prevalent in westernised cultures and more prevalent amongst girls than boys, although the rates are much higher in certain groups of boys than others, and being an adolescent. There's been quite a lot of work looking at biological risk factors. So occasionally we get all excited because someone's isolated a gene that explains anorexia nervosa, and then of course they'll replicate the study and it's gone. We're holding out quite a lot of hope for genome-wide studies because that allows us to look at genes more broadly rather than isolating one at a time. And also serotonin dysfunction. There's been quite a lot of work done on that. We know that serotonin the function is impaired in people with eating disorders, but we also know that's a consequence of some dietary factors, including low carbohydrate intake. So really, the underpinnings of this, and it's well regarded within the field, that the underpinnings are psychological. So in terms of specific risk factors, other things we know. So we know that someone is more likely to develop an eating disorder if they have a family history of depression, substance misuse, a family history of eating disorder or obesity. So lots of eating disorder patients will say, my mum was really overweight, or my older sister or my older brother were really overweight and I really hated that, and they kind of internalise that, or families where there's chronic dieting. In terms of individual characteristics, we've already talked about low self-esteem and perfectionism. People who already have an existing anxiety problem or are overweight themselves, so lots of patients were previously overweight, or those who start their periods early, so in girls who menstruate earlier, that's a risk factor. And then there's the stuff around experiences, and these are the things that we can begin to think about how we try to moderate some of these experiences. So invalidating environments, we did a few studies a few years ago now looking at the sorts of experiences that people with eating disorders have growing up. And quite often patients will say, when I was growing up, if I was upset, I'd be laughed at. Or if I was angry, I'd be yelled at or sent to my room. Or, you know, if I was crying, I'd be told to just stop being silly and get on with it. And we came up with this construct around emotional validation. And that's the allowing children to appropriately express and deal with their emotional states. If we don't allow them to experience those emotions, they're not going to learn how to deal with them. Really, really important. We also know that a significant percentage of people with eating disorders have suffered emotional, sexual, and physical abuse. There was a study a few years ago showing that up to 40% of bulimia nervosa patients had been sexually abused. So that's a huge risk factor. And being subjected to critical comments around eating shape and weight and pressures to be slim. We've done lots of work in the past with PE teachers, sports coaches, across all sorts of levels. And we know that those factors are important. So what I'm going to do, just to finish off, is talk about how these things fit together. And I'm going to present one of the underpinning models that guides treatment for eating disorders globally, not just in the UK. I'll talk you through it. Don't panic. So fundamentally, we've talked about it, low self-esteem. When someone feels really bad about themselves, it means that they start to over-evaluate the importance of two things. One is achieving. So that's where the perfectionism comes in. That's why people with eating disorders tend to be the best dancers, the best academically. They have the best friendship groups, and they have, they really want to be the best at whatever they do. And that leads them to achieve. It also gets them to over-evaluate the importance of shape and weight and the control thereof. So if someone's feeling really bad about themselves, they think, if I lose a bit of weight, I'll feel much better. And of course, as soon as someone does lose a bit of weight, they get really good reinforcement from that. Oh, you've lost weight. Attention and reinforcement. And that leads them to start dieting. And when people diet, one of two things happen. They either get into a spiral of dieting, we call it the starvation syndrome, where both psychologically and physiologically the effects of starvation mean that they become stuck in that pattern. I'll give you one example. If people haven't eaten for a very, very long period of time, and then they eat a small amount of food, they feel fat. They feel full and fat. So that physiological response means that the dieting is maintained. Or they lose control and binge eat. And obviously, binge eating magnifies again that overimportance. I need to lose more weight. I've blown my diet, etc., etc. Now, fundamentally, people do this because it enables them to regulate their emotional state. So people report binge eating more when they feel angry, when they feel depressed, and these are on a day-to-day basis rather than looking at trait levels. So people will say, I had an urge to binge and I was really, really angry, and that's when it happened. Yeah? So they're doing it because when they're binging, preparing and eating a vast amount of food, they're not thinking about the time that they were abused or the fact they didn't get their A star. It's the same with starvation. When someone feels that hungry, they're not thinking about the other things that are going on in their life that's worrying them, the fact their dad's left or whatever it might be. So really, really important that we understand, I think, that we understand the fundamental reasons why people engage in these sorts of behaviours. So what can we be done about it? Right, first thing we need to do is whatever we can to reduce the incidence of these problems. We need to reduce some of those predictors, and self-esteem and perfectionism are really important, and we need to build people's resilience towards them. Now, perfectionism is a really interesting topic, so we've done quite a lot of work in my group looking at perfectionism. We are all perfectionistic here, otherwise we wouldn't be here. We all set high standards for ourselves, but what we've done is broken down perfectionism into those high standards and a self-critical type of perfectionism. It's fine for children to have high standards for themselves. It's what they do when they don't meet them. That's the critical thing. Working in a university and working in that sector for 20 years, the number of new students that come to university having always got A's and A stars, the first time they get a 2-2 for a piece of coursework, they fall apart, or when they don't make the team, or whatever it might be. And it's about enabling them to have the resources they need to deal with that lack of success. We also need to ensure that our schools are equipped to deal with these problems when they occur, and I'm going to talk about that in lots more detail this afternoon. And I feel really passionately about the fact that we know quite a lot about these sorts of disorders, whether it's self-harm, whether it's eating disorders, whether it's depression, anxiety. And we need to empower teachers and schools in order to be able to feel confident in dealing with them. And one of the things that we're working on quite vigorously now is developing early intervention, so developing screening tools and early intervention to support pupils in that environment. And so one of the things, I know it's already been mentioned, and I'm going to talk a little bit more about it this afternoon, one of the things that we're doing is trying to plug that skills gap. So we've developed the first in a series of courses. It's been launched, and it's on understanding eating disorders for children and for teachers and schools. And we're also developing content for courses around self-harm, building resilience and self-esteem, and gender issues, as well as one for teachers. So I'll talk a little bit more about it this afternoon. And I should probably say that I have no personal financial investment in this. I'm paid by the university. But this course basically is a short course that people can do over a period of several weeks rather than take out a day from school. So in summary, I think there's evidence for our knowing that there's mental health issues in schools. We have quite a lot of evidence base around the risk factors. We're quite good at knowing what causes these issues. There's definitely a skills gap. And I think it's really, really important that we begin to collaborate across schools and universities. I also think it's really important that we develop content that schools actually feel they need. So what we're doing is working with teachers, with parents and with pupils to co-produce all of the materials. And I think it's important that together we have some political influence. We need to make some changes to what we're doing to these children. It's really, really important. Thanks for listening.